Hello and welcome to Health Buddha's Lunch and Learn webinar on labs and treatment options for PCOS. Before I introduce our guest, naturopathic Dr. Jodie Peacock, I'd like to thank all of you for joining in with us today. For those already here, if you would love to take a moment and say hi, introduce yourself in the chat. And in the meantime, as we wait for others to join in, I just want to ask that throughout the duration of the presentation, if you can just ensure that your mics are off. And if you have any questions as Dr. Jodie is presenting, please feel free to pop those into the chat and we'll be sure to address those at the end of our session. Without further ado, I'd love to introduce our guest speaker, naturopathic Dr. Jodie Peacock. She is a practicing naturopathic doctor in Oakville, Ontario. She is an alumni from CCNM 2006, and her practice focuses on hormone health and fertility. She's the author of Preconceived and the founder of the Canadian Fertility Show. She's currently on the board of directors of the OAND and is really passionate about supporting naturopathic doctors and the health of Ontarians. Welcome, Dr. Jodie Peacock, and thank you so much for being with us today.
Thank you, and thank you for the lovely introduction. I appreciate it. So I guess we will get started. So I'm just going to go ahead and share my screen. For those of you listening, if you do have kind of quick questions as I'm going through, I'm happy to answer those as we go along as well. That's no problem. So yeah, happy to kind of make it as interactive as we can as well. So again, pop in if you want. If you have questions, please feel free to ask those. So for today, we are going to be talking all about polycystic ovarian syndrome, or PCOS. Just to give you guys a bit of background, I mean, I was just introduced. I do also work with NFH. I've worked with them since 2008. I've been in practice since 2007. While I was at naturopathic school, I was actually diagnosed with PCOS myself. So that is kind of one of the things that started me on this journey to support women with hormonal health, with their fertility, and also why I founded the Canadian Fertility Show. So in today's lecture, by the end, you should be able to be pretty confident with diagnosing PCOS, be able to have a better kind of understanding of what's happening with all the different hormonal cascades and how these are implicated in different symptoms that patients will be presenting with, as well as have a really good idea about what different treatment options you have to offer these patients. So just to give a quick background, we know that PCOS is the most common endocrine disorder that is currently being diagnosed in women of reproductive age. So somewhere between 5 and 10% of women are actually diagnosed with this concern. And the common symptoms that patients will often present with will be an irregular absence of menses, not ovulating. They will have hirsutism or potentially hair growth, cystic acne, kind of unexplained or uncontrollable weight gain for some, elevated androgen or testosterone levels, and some patients will also have poor blood sugar regulation. So in terms of the kind of official way to diagnose PCOS, we do need to follow the Rotterdam criteria. And basically what that means is patients need to have 2 of the 3 of the following. So that's either an irregular or absence of ovulation, elevated androgen levels when you run their blood work, and when a transvaginal ultrasound is performed, we'll see a high level of follicles that are developing in the ovaries. So, there would be at least 12, but it's not uncommon to have 25 plus in each ovary developing each month. Some women will have concerns around their insulin. Other patients with PCOS tend to be a little bit more adrenally focused. So, not all patients that present will have blood sugar regulation concerns. In terms of kind of a general presentation, when will these women show up in your office? So they may come while they're a teenager, coming in with things like an irregular or late menses. Cystic acne is a very common reason why women may present with this into your office or at their family doctor. Typically, if they've presented to their family doctor with these concerns, the recommendation will be an oral contraceptive. This will basically help regulate their cycle. It will also often help with some of that acne. And if it's not kind of enough for them, then typically they'll be prescribed, Accutane or some type of pharmaceutical medication to help with the acne. Now, the kind of negative part of this is this does not address the underlying root imbalances. So, if this patient doesn't present to your office at this early stage, but they, present to their medical doctor, they often will show up at your office when they've decided they're ready to get pregnant. So that's kind of where this fertility piece often comes into play. So they'll show up at your office, they'll say, I have had irregular cycles, I've been totally regular since I've been on, the OCP, but now I want to get off birth control and I haven't had my period back, or my period's very irregular. Their acne is probably getting worse again for them, because none of those underlying imbalances were actually addressed by using those medications. Now, just a quick kind of background, your DHEA does convert to androstenedione. This can go in two different pathways, either to testosterone or to estrone. And then you also have the interconnection with the 17-beta estradiol that's going to play a role. So as we go through talking about the different hormones, just kind of keep this picture in mind so you can kind of work back to see where, someone might be stuck in these pathways. So in terms of kind of hormonally, what is happening with these patients? So typically the androstenedione and the testosterone in the peripheral blood of PCOS patients is elevated. So this excess in androstenedione is converted to estriol. That in turn is going to stimulate the pituitary gland to secrete luteinizing hormone, or LH. With LH increasing, this regulation actually leads to your FSH dropping. So when that drops, we also will see that will drop from the elevated androgen levels. So we get kind of this negative feedback loop that starts happening that will impact basically kind of the stimulation to the developing follicles. And so again, that kind of high androgen does inhibit the maturation of the follicles. So we know when we test follicular fluid in PCOS patients, these are some of the concerns that we will see. We see low estrogen levels, we see elevated testosterone, elevated interleukin-6, and low melatonin. So these all are going to play a role in developing kind of a healthy follicle that's actually going to be able to ovulate and potentially result in a pregnancy. With those high androgens, one of the ways that they are kind of causing a problem with follicles is by reducing the amount of 17-beta estradiol that's being secreted. And that E2 is very important for follicle development. So often what we'll see is, when someone goes in for kind of transvaginal ultrasounds, they see lots and lots and lots of follicles developing, but none of them develop kind of to the size that we want to see, that we know is kind of consistent with being able to ovulate and to be able to be of good enough quality or mature enough quality to actually be able to form an embryo. So in terms of relevant labs, we are going to go through these. So I just wanted to kind of give an overall of like, these are the items that are going to be important. Some of these are going to be more important in certain situations with your patients than others, but all of these can be relevant for our patients. So when we look at kind of that androgen side of things, our DHES is a hormone that's secreted by the adrenal gland that then converts to testosterone. Elevated levels can be caused by things like PCOS, stress, tumors, Cushing's, hyperthyroidism. Then we want to kind of look at our total testosterone level. Elevated testosterone can contribute to anovulation, to that hirsutism or hair growth, also to acne presentations. Then we also look at free testosterone and sex hormone binding globulin. So these three, when we're looking at total testosterone, free testosterone, and SHBG, all will kind of have an interplay with one another. So sometimes a patient might present and their testosterone is normal, but their SHBG is actually low. And then when you run their free testosterone, it's actually elevated. So running just kind of total testosterone is not going to be enough to really give you a picture about what's happening from an androgen standpoint. On the other side, we can also see, a high total testosterone, high SHBG, but then a normal bioavailable or free testosterone. So I do think it's really important that you're making sure you run all three of these to get a good idea about what's happening. In terms of kind of glucose and insulin, we do know that there are a significant number of patients that do struggle with insulin resistance, so somewhere between 30 to 40%. So that's a good number of people. Yes, we will send a copy of the slides, so that is no problem at all. With insulin resistance, so when we're talking about insulin resistance, this doesn't necessarily mean that a patient is going to have elevated fasting glucose, but often, they will have elevated fasting insulin. So again, this is an area where, if they've seen their kind of regular family doctor, they often will have had their fasting glucose measured and it might look perfectly fine. But then when you kind of dig a little bit deeper and you run that fasting insulin level, you see, okay, this is elevated. So that is a concern. With this kind of type of concern, this does leave women more prone to type 2 diabetes. And so, when we're, oftentimes, again, when women are coming in with PCOS, they may be kind of on that path of they just want to get pregnant, and that's why they're seeing you to begin with. But we also need to look at this as a metabolic disorder that, over the long term for their lifespan, we want to be making sure we're giving them good advice from a preventive standpoint on how we can help them prevent developing type 2 diabetes, how we can stay on top of kind of cholesterol levels and inflammatory pathways. So this is an area that again, doesn't impact all women with PCOS, but can be very relevant for a good number of them. Then we can look at, again, our androstenedione. So with this, it's your precursor to glutathione, to aldosterone, testosterone, and estrogen. So in peripheral tissues in women, androstenedione gets converted to testosterone and then on to estrogen. So if that conversion piece isn't happening, this is one of the reasons we can see that elevated testosterone. We also will see elevated levels in, so with kind of that androstenedione, you'll see high levels in patients with PCOS. But often you'll see, kind of just getting into that fertility piece a little bit more in women that have been diagnosed or are, potentially going to be diagnosed with primary ovarian insufficiency. You'll actually see a decreased level. So just something to keep in the back of your mind, but not necessarily relevant to your PCOS population. When it comes to prolactin, this is a hormone that's secreted by the anterior pituitary gland. It really should only increase when someone is actively lactating. So obviously towards the end of a pregnancy, we can see it come up. If someone is nursing, we should see it come up. Outside of that, though, it should be at a low level. So if you are seeing an elevated prolactin level, there are multiple different reasons that could be happening. We see it often with high stress. We see it with secondary amenorrhea, PCOS, anorexia, high level of exercise as well. We can sometimes see it. And then you do need to rule out pituitary adenoma. So if you are seeing an elevated prolactin level and you're the first kind of practitioner that's run it, you should be referring this patient back to their family doctor to get a further workup so that we can make sure we rule out an adenoma. Thyroid. So this is quite interesting. There's been more and more research coming out showing that women that have been diagnosed with PCOS have a much higher propensity to also be diagnosed with Hashimoto's thyroiditis. When we look at kind of thyroid from a fertility standpoint, we certainly want to be targeting a TSH of under 2.5. And I really don't really understand why, if that's what the optimal range is for fertility, a person who is not trying to get pregnant, why is it okay for them to have a higher TSH level? So I think that 2.5 really should be kind of our benchmark overall, not the 4.5 that will get listed by most of the common labs. In terms of your free T3 and T4, you definitely want to be looking at these, and they should be kind of in the middle of the reference range. And then oftentimes, either just TSHs run, or, they may have a TSH and a T4 run, but, if these are not in good range, oftentimes antibodies are never looked at. So the two antibodies that are relevant when we're looking at thyroid function are anti-TPO and anti-TG, or anti-thyroglobulin. So with these two, you should not have either of these present, right? I mean, sometimes they'll show up at a very, very low level. That's not of concern. But I do, see more often than not patients that their TSH, their T3 and T4 actually look fine. But then when we run these antibody levels, because perhaps, usually there's kind of an underlying symptom, like there's something that's kind of making me think, okay, there might be an autoimmune component to this, particularly again in our fertility population. These can sometimes show up elevated when everything else looks normal. So it is something that we want to be aware of and then be able to address for our patients. With our kind of regular female hormones, your luteinizing hormone and follicle stimulating hormone, these are ones that come from the pituitary gland. Your FSH is the one that obviously is called follicle stimulating hormone. It, stimulates the follicles to develop. Luteinizing hormone is your trigger for ovulation. So when you run these two labs, if the ratio of LH to FSH is higher than a 3-to-1 ratio, this can kind of aid in your diagnosis of a PCOS picture. Elevated FSH if you're just seeing kind of a high FSH level, this is typically more likely going to be, a diagnosis of primary ovarian insufficiency, or this patient is in menopause. So depending on their age and what their kind of fertility objectives are, that's going to be a conversation that you need to have with them. With estrogen, typically I find most of the time, if you're running a blood level of estrogen, it comes back in the normal range. With PCOS patients, I mean, there are some patients where it will come back elevated, but typically it does come back in normal range. And then the other thing that we want to look at is our progesterone. And with progesterone, ideally, we're going to test it 7 days before the expected pregnancy, or not pregnancy, period, sorry. But, oftentimes our PCOS patients don't have a regular cycle, so that's very difficult to pinpoint. So, sometimes I'll just run it to see where it's at for them. And then as we kind of get a cycle started or going with some more regularity, then we can check it at that point to see if it is, in a normal range or if it's on the low end. Again, if we're working towards the goal of maintaining a pregnancy, we want to make sure progesterone is in a good range so that, through that first 6 to 10 weeks, we have enough substrate there to maintain the pregnancy. So the other piece that we often will see happen with women with PCOS is kind of a low-grade inflammation or inflammatory picture. This level, if CRP is elevated, we know that's a risk factor for cardiovascular disease. So again, kind of going back to that big picture with these patients, seeing elevated CRP is not a positive thing for their cardiovascular health. And definitely if you're seeing this before a potential pregnancy, you want to make sure you're addressing this before getting pregnant. AMH levels typically are elevated in our PCOS patients. So AMH is a marker called anti-Müllerian hormone. This typically will only get run, if somebody is considering going into an IVF cycle. But it also is something that women, sometimes are running more often now, just to get a bit of a benchmark to assess kind of future fertility. We don't necessarily have a good handle on, how important AMH is around that fertility piece. Basically, if you have a lot of follicles developing, it tends to be on the high side. So that's where we will see that happen often in these PCOS patients. On the flip side, if it is really low, often those patients are not developing very many follicles each cycle. So if they are going into an IVF cycle, medication will be addressed differently with a low AMH versus a normal AMH. Now, the other thing that we can see as well is a really high level of AMH sometimes can actually inhibit follicle development. So that obviously is going to be problematic if we're trying to get pregnant. And there are kind of preclinical studies that suggest kind of elevated levels of AMH may actually be a contributing factor to the pathophysiology of PCOS, as well as some of the other reproductive diseases. The other thing that's important to be aware of, again, this is going to be more if they're working in a fertility center, is at that elevated AMH level does leave a patient at much higher risk for ovarian hyperstimulation syndrome, or OHSS. So with that syndrome, basically, it causes a lot of pressure and pain in the ovaries for women. So this is definitely something that we want to avoid for them. You also can't do a transfer, if you have OHSS. So it's something that the doctors are generally quite aware of and will reduce kind of stimulant medications around it. But it is kind of a conversation you want to be comfortable having with your patients. So when we that kind of takes us through the lab component, as a naturopathic doctor, what kind of health concerns are you often addressing with these women? So one, are they ovulating? So if not, that's something that we want to be kind of focused on getting cycling again. Is their weight a concern? Is the quality of their embryos or the quality of their follicles a concern? Are we seeing elevated estrogen, elevated androgen levels? Is that blood sugar regulation an issue? And then also that cortisol regulation can also be a big concern. So potentially, we were talking about diet with patients. Here, we really want a huge focus on fruits and vegetables, lean proteins. If the patient has decided to be, has chosen to be a vegan or a vegetarian patient, this can be a big challenge, I find, with the PCOS population. I put here, you want to be getting at least 80 grams a day of protein, but I often find that women will actually need significantly more than that. So, it's not uncommon to be at the 120 to 140 grams per day. So that can be quite challenging to hit from vegetarian sources. Often we'll need to incorporate some type of protein powders in if that's the case. So you just want to make sure that that isn't something that's being missed for these patients. We definitely need to make sure we have enough high quality healthy fat. It makes the entire hormonal cascade harder to develop, right? We need to make sure we have adequate cholesterol so that we're able to make all these different hormones, and without adequate fats in the diet, that's very difficult to do. And then we typically will look at minimizing, certainly eliminating kind of refined sugars. And, oftentimes these patients will do better on a low grain or no grain diet. Now, this doesn't mean we're eliminating carbohydrates. We certainly have a lot of vegetables that have good carbohydrates. I'll look at a lot more kind of beans, legumes, lentils for these patients because they're high in fiber, they're high in protein. and you're still getting that kind of complex carbohydrate piece from it. So it's not about eliminating carbohydrates, but it's eliminating the ones that aren't serving us well, those kind of more refined and fast absorbed carbohydrates. So the other thing that I have found, this is going to be more so for your kind of glucose insulin patients, is intermittent fasting. So when we look at, kind of a 16 and 8 ratio with intermittent fasting, I find is typically the easiest for most patients to follow. Essentially, that means, they have a 16-hour window where they're not eating, an 8-hour window where they are. And kind of during that 8-hour window, you can either do kind of 3 meals in that time, or kind of 2 bigger meals and a snack. But that kind of reduced amount of time to actually consume your calories, we see a lot of benefit in terms of insulin growth factor. We see improved fasting insulin levels. We see increased leptin levels. And all of these are going to have a very positive effect on ovarian function, on excess androgens, and on infertility for this population. So leptin and ghrelin are 2 hormones that are really relevant when it comes to, kind of our feelings of hunger, our feelings of satiety. And one of the things that's kind of interesting with these is, okay, so ghrelin is the hormone that gets secreted when you're hungry. That's kind of the guy that comes out that says like it's time to eat. Leptin gets secreted when you're full. But often patients with PCOS have reduced sensitivity to leptin. So even though the leptin is getting secreted, it's not necessarily binding to the leptin receptors. And so they don't necessarily get that feeling of being full. And so when that happens, it becomes a lot easier to overeat. So this is going to be kind of particularly relevant to your, overweight PCOS patients. But this is also something I will often kind of see in my athletes as well. So, a lot of, your kind of elite or higher level athletes actually do have PCOS. And, when they're younger and they're training really hard, either, they may not have a regular menstrual cycle. And it's often kind of put down to, it's probably because they're training so much that this isn't an issue. That, slightly elevated testosterone levels certainly give these women a competitive advantage when it comes to athletics. So, the PCOS diagnosis isn't all bad. But where, I find it starts to kind of catch up with women is as they kind of maybe reduce the amount of training that they're doing for their sport. When they finish university, maybe they're not training at that high of a level. So when they lose that kind of high level intensity exercise piece, then that's when we often will start to see some of these insulin and blood sugar regulation concerns. And then, so these are often women, that they could eat, huge amounts before when they were training because they needed that to sustain their energy. But now that they're not training, they don't need that. And they're not getting that signaling to tell them that they're full as easily. So with leptin, again, there is basically a soluble leptin receptor that circulates in the blood where leptin binds. We know that, when we look at the leptin levels and the free leptin index in women with PCOS versus controls, these levels are they are altered compared to your controls. So we also know that your BMI is correlated with your leptin and your leptin receptors. So this is something that is a real concern with these women. With intermittent fasting, this is one way that we can see higher leptin secretion. HIIT or high intensity interval training, we know also can increase leptin, as well as reducing systemic inflammation. When we get the inflammatory levels down, we actually see improvement with that kind of receptor site for the leptin receptors, so that the leptin that is circulating now can bind and we can get that proper signaling happening that we don't need to continue eating. So in terms of exercise, We know exercise helps reduce elevated androgen levels. It contributes to better egg quality. It does help regulate ovulation. And we see kind of the most positive impact with women who are undergoing moderate exercise, 5 or more hours a week versus less. Definitely, if women are kind of up for it or interested, that high intensity interval training can be really helpful component. And again, depending on where this patient is at, like if they are someone who was an elite level athlete, that HIIT train is typically a very easy place for them to start. If you're dealing with someone who has never been athletic before, that high intensity interval is really where they are at. So, for some patients, we'll get them to start with just doing picking, full body type exercise. So maybe squats, for example, and they'll do that for, 20 seconds, take a 10-second break. There's timers that you can download to kind of help them with it, where they're going to go kind of as hard as they can for 20 seconds, take a 10-second break, do 10 rounds of that. So you're doing 5 minutes. That even just doing that, we'll see an increase in that leptin levels. So, it does not have to be a full kind of hour class where things are crazy high intensity. It's really about, getting that patient moving, getting the heart rate up, and kind of doing that really hard work for a very short period of time. So what does moderate exercise look like? So basically kind of 30 to 60 minutes, 5 to 7 days a week. And with moderate, we're kind of aiming for 50 to 70% of max heart rate. So for patients in their 30s, that's going to be somewhere between 140 and 160 beats per minute. With some women are able, again, depending on their fitness level, you may be able to hit this going for a brisk walk. For other women, they're going to, have to be increasing that intensity level to be able to hit that heart rate. So again, meeting them where they're at, coaching them through it. If exercise isn't kind of a big part of your practice, having a good personal trainer that you can refer patients to is also a great idea. So when we look at some of our different supplement options, Myo-Inositol plays a very kind of important role when it comes to the ovary. It does actually help in glucose uptake into the cells, so that's going to help energy status. We see improvement in FSH signaling, so that's going to help with oocyte maturation. And then in PCOS, we do see some pretty significant changes with different hormonal balance. So often we can see improvements in regulating ovulation, in ovarian function. We can see decreases in serum testosterone, improved insulin sensitivity, and it also does decrease the risk of that ovarian hyperstimulation syndrome that we talked about earlier. With inositol, when it comes to egg quality, there was one trial that looked at 175 women that were doing IVF that had been diagnosed with PCOS. They used 4 grams a day, and they found that pregnancy rates actually were significantly better. We also see further benefit when we combine Myo-Inositol with melatonin, and we will talk about melatonin as we continue through. So here we saw reduced hyperinsulinemia, so improved insulin sensitivity. We saw better balance between luteinizing hormone, prolactin, and testosterone. N-Acetyl basically, we know it works as a precursor for glutathione in the liver. Women that, have been diagnosed with PCOS, that were undergoing an ICSI procedure took either kind of 600 milligrams of NAC 3 times a day, or 1,500 milligrams of metformin for 6 weeks leading up to egg retrieval. And they found that both metformin and NAC certainly outperformed placebo and saw less immature or abnormal oocytes, higher number of good quality embryos. And so this study actually concluded that NAC would be a viable alternative to metformin in this type of situation. So for those of you who, haven't had patients use metformin before, for some women, it does cause a lot of digestive upset. So isn't something they, if they have another option that can work just as well, they're often happy to look at that. Now, with melatonin does play a role in steroidogenesis, folliculogenesis, and oocyte maturation. Both melatonin and its receptors have been detected in the primordial follicles themselves. So those follicles, kind of before they even start to develop, they do have receptor sites where melatonin does play a role. We know that levels of melatonin in follicular fluid are, particularly high right before you ovulate, and they're especially high around the large antral follicles. So those are the follicles that typically will be the ones that end up ovulating. So we also know that follicular atresia, so basically, as we kind of talked about before, that high testosterone level will often suppress the amount of estrogen that contributes to the developing egg. So a lot of times we'll see, again, a lot of really small follicles that don't develop into a dominant one, and melatonin can actually help prevent some of that from happening. Also protective against free radicals in developing eggs as well. So 40 women, normal weight PCOS, melatonin treatment, we saw decreased androgen levels, we saw decreased FSH, decreased AMH levels, and almost 95% of participants saw improvements in their menstrual cycle. So that's a huge component. So definitely we do not want to be overlooking the use of melatonin in our PCOS population. So otherwise, we also can see improvements in that IL-6, TNF alpha, interleukin 18. These are all things that, have been demonstrated to be higher in PCOS patients that after melatonin administration started to come down into normal range and were regulated more effectively. With CoQ10, there is, again, some good research in PCOS. So this one trial used just 100 milligrams of CoQ10 a day over a 3-month period. We saw improvements in kind of that insulin lipid metabolism, improved inflammation. At higher doses, we also saw, so for patients that were poor ovarian responders, 200 milligrams 3 times a day for 2 months before IVF showed basically more embryos that then survived to day 3. So in the treatment group, only 8% of women had no day 3 embryos, where 22% in the placebo group did. With acetyl-l-carnitine or carnitine tartrate, these are fairly interchangeable when it comes to, this reason that we're using it with PCOS. We know it is an antioxidant. It has a protective effect on growing embryos. Carnitine is important for transporting long-chain fatty acids across the mitochondrial membrane. So if someone is deficient in carnitine, it is much more challenging for them to get those fatty acids into the mitochondria and create the energy that we need for, we know mitochondria are in all the cells in our body, but certainly when it comes to reproduction and egg quality and egg health, we need enough energy to make sure that when we're going through DNA replication, we're able to have that happen. So there is, one kind of study, an in vitro study that looked at using carnitine in embryo cultures that had been challenged by oxidative stress. And they saw with the addition of carnitine, reduced DNA damage, improvement in chromosomal structures, and improved development in the blastocysts. So certainly those are all going to be very important parameters when we're trying to get pregnant. With PCOS specifically in non-obese PCOS women, there have been kind of studies that looked at carnitine and showed that, oftentimes these women are deficient. We also can see, again, those low levels of SHBG compared to healthy women. Low levels of carnitine have also been linked to the hyperandrogenism and to insulin resistance. So These are, again, very important components that are going to leave patients very symptomatic. So if it's as simple as getting more carnitine, in through the diet or in through supplementation to see some of these things starting to improve, that's, extremely helpful for these women. One, trial that looked at 85 women that had been diagnosed with PCOS that were clomiphene resistant. So clomiphene or Clomid was a very common medication that used to be used a lot in our fertility patients. We don't see it used as much now as before, but a lot of kind of the older studies will kind of compare some of our natural interventions to using it in patients who had been using Clomid because it was such a common medication. And here we found that 3 grams when a patient didn't respond to Clomid, but then they gave them Clomid and 3 grams of carnitine, we saw better ovulation and pregnancy rates, better BMI as well. And also improved lipid profile. So cholesterol is definitely something we also want to be aware of and looking at with these. Alpha lipoic acid can be helpful. More so, I think this is going to play a role in your PCOS patients that do have an insulin concern. We know alpha lipoic acid has a lot of research in type 2 diabetics as well. So I think this is more so where it's playing a role here in terms of metabolic parameters. So in this study, they used alpha lipoic acid and Myo-Inositol in 36 obese PCOS patients, found improved metabolic parameters, better oocyte quality after 3 months of use. We also don't want to overlook our kind of basic nutrients. So folate, B12. We know kind of homocysteine concentrations are higher, and B12 is often lower in PCOS patients that have insulin resistance compared to those who don't. We also saw significantly decreased B12 levels in obese PCOS women compared to obese control women. So, it's not necessarily a weight issue, it's that PCOS component. We also know methylated folate does increase peripheral sensitivity to insulin. And, if you're deficient in folate, we can also see elevated homocysteine levels, which we know are risk factors for cardiac concerns. So we definitely want to be looking at these 2 nutrients as well for these women. Your omega-3 fatty acids can also play a role with helping PCOS patients. So in this trial, it went over 6 months. These were, again, non-obese PCOS patients who were given 1,500 milligrams a day of omega-3 fatty acids. At the end of the trial, we saw improvements in hirsutism, fasting insulin levels, decreases in testosterone and luteinizing hormone, and increased sex hormone binding globulin. So this is, something you can look at supplementing, or we can really encourage our patients to eat more cold water fish. So typically, if they're eating fish at least 3 times a week, they'll be able to kind of hit these levels without having to supplement. And then vitamin D. So with vitamin D, we know deficiency has been linked to infertility. There are multiple studies that have shown women with sufficient levels are more likely to achieve a spontaneous pregnancy and have better quality embryos if they are going through an IVF procedure. There was one study that looked at vitamin D levels in PCOS patients and found 85% of the women were deficient. So that is a really high number. So please make sure you're checking women's vitamin D levels if they've been diagnosed with PCOS. I mean, we should really check anybody's, at this time of year, but this population in particular is going to be really important. We also know that low levels of D are associated with insulin resistance in PCOS, and obviously deficiency is linked to a whole other host of concerns. So in terms of, should we be testing for vitamin D? Yes, running that 25 hydroxy vitamin D level, I think, is very important. And then it's also important to make sure that we're following up, 2 to 3 months after starting, our vitamin D therapy to make sure the dosing is effective for the patient. Typically, if you're seeing a bottom basement vitamin D, you're going to be recommending 8 to 10,000. I use a day for that kind of 2 to 3 month period, and then checking again to see if we're now in sufficient range. If you don't have your prescribing license, then you're going to be referring that person to someone who does, to be able to dose those kind of levels, because the 2,000 I use in someone that's deficient is typically not enough to get them to a sufficient range. So, summary, with your PCOS patients, we are looking at making sure they're exercising. Again, this is meeting them where they're at. It could be, as simple as starting with walking most days of the week, right? And then increasing intensity as they get more fit. Limiting those refined carbohydrates, potentially all grains, ensuring you're getting enough healthy fats, getting that, cold water fish in at least twice a week, ideally a little bit more. Make sure you're hitting those protein levels. And then you can obviously consider some of these nutritional supplements that we've just talked about. So I think we've left enough time for some questions. If anybody has any, I am happy to answer those now.
No other questions have come in, but I'm actually curious to ask, especially since, if we're talking about PCOS, we're talking about the fact that there is such a strong metabolic component or presence, obviously not across the board, but nonetheless, in your experience, I'm really curious to know how often you see patients that are coming to you, especially on the fertility journey. Let's say they successfully conceive. How often are you seeing these patients develop gestational diabetes throughout their pregnancies?
Yeah, so definitely there is a higher risk of gestational diabetes in women with PCOS. Because of that, I mean, if they're my patient kind of from the onset, like they're not coming to me mid-pregnancy with being diagnosed with gestational diabetes, essentially all the things we put in to play before they get pregnant, I will continue through their pregnancy. So that I have had some decent success with not having women then diagnosed with gestational diabetes, but absolutely, if they haven't done any of that work ahead of time, the risk is really high. And then we know when you develop gestational diabetes, the risk of your offspring having type 2 diabetes is also significantly increased, right? Yeah. So it is such an important time to, address those issues. And I mean, I remember this was probably 5 or 6 years ago, going to the Fertility and Andrology Society, their annual conference. And one of the speakers was there talking about, PCOS and gestational diabetes and kind of their kind of take or thoughts on it were, we need to look at, using like a metformin during the pregnancy preventatively. And so, I kind of stood up and said, well, okay, what about using, Inositol and NAC? And they were like, well, there's no research on that. And I said, well, is there research on metformin? No, there wasn't. So I'm like, well, how are we comfortable using the pharmaceutical, but not the age? So yeah, the thing that does get a little bit tricky is obviously when things aren't studied in pregnancy, you need to have a certain comfort level, talking to your patients about, okay, why are we using this? Why are we continuing this during a pregnancy? And some women will say, and I'm not comfortable, using this because it hasn't been studied. And obviously that's their prerogative. They need to do what, feels comfortable for them. But then, if they do end up being diagnosed with gestational, that's when they usually will come back and say, okay, you were maybe we should have looked at that. And what can we do now? Right. And so then they're often more willing at that point. And I mean, we do as much as we can through diet, obviously, as well, but it is a very legitimate concern for sure.
Yeah. And I mean, it's a tricky time, right? Because as they're kind of heading into that, end of second trimester, beginning of third, that is just a time where there tends to be more of that insulin resistance present anyway. So it's kind of just a double whammy almost, right?
Well, and especially if you still have a little bit of underlying inflammatory happening, you don't have good leptin control, like that's when it can really, get out of control with like, I'm eating for two and feeling comfortable with that. And now all of a sudden we gained, 70, 80 pounds and we're 6 months into a pregnancy. I'm like, okay, that's not healthy for you. Right. So it's an important conversation to be having for sure.
Awesome. Well, thank you so much, Dr. Jodie. If anyone has any more questions, you can email us at hello@healthbuddha.ca, and please follow us on Instagram at healthbuddha.can for upcoming webinars. And we will be sure, thank you, Dr. Jodie, for allowing us to share the PowerPoint presentation. So we will be sending that out to everyone who has joined today.
Yeah, awesome. Well, thank you so much. I really appreciate it.
Thank you.